Hello all. We will continue our discussion about peptic ulcer diseases, drugs for peptic ulcer diseases. A brief review of your previous class. We have mentioned about the definition of peptic ulcer, the pathophysiology, the factors which leads to the formation of peptic ulcer, the aggressive factors and the defensive factors, regulation and acid secretion, and some details about the parietal cell and the production of acid in our parietal cell. And we also see the classification or group of drugs used in peptic ulcer. The first group was the group of drugs which reduces the acid secretion, which included our proton pump inhibitors, H2 antagonists or H2 blockers, and third group anticholinergic drugs. These anticholinergic drugs are not used nowadays or obsolete nowadays. That's why I just mentioned the name, and I'm not discussing much about these anticholinergic drugs. The second group of drugs is neutralizing, the drugs which neutralizes the acid, already produced gastric acid, also known as antacids. Then the drugs which enhances the mucosal defense, fourth group, which are ulcer protective, and the last drugs used as anti-H. pylori drugs. Okay, so this was the classification. So we have already seen the first part, that is the drug reducing acid secretion, mainly the proton pump inhibitors and H2 antagonists. So the rest of the drugs we'll be seeing today. Antacids. So antacid means they will neutralizes the acid, already produced acid in the stomach. So there is no role on production of acid, but it can neutralizes the acid which is already produced by the parietal cells. The weak bases that neutralizes the acid. So these antacids will be a weak base which will neutralizes the acid. Our chemistry, the acid will neutralizes the base. And also these antacids can inhibit the formation of pepsin. The reason is pepsinogen is converted to pepsin. We know that the pepsinogen is the inactive form of pepsin. So pepsinogen should be converted to pepsin first. And the pepsinogen will be converted to pepsin only in acidic pH. So when we are using an antacid, it will neutralizes that acidity, and the production of pepsin will be inhibited. Okay. And when there is no acidity, or when there is no acidic medium in our stomach or in the duodenum, it will help or it will increase the mucosal defense. So the aggressive factor is reduced, so the defensive factor can act more, and it promote mucosal defense. And it do not reduces the volume of HCl secreted, that I have already mentioned. That means they have a power to neutralize the acid only. There is no action on acid secretion, there is no action on the parietal cell, there is no action on the H2 receptors, there is no action on the histamine, or there is no action on the H plus K plus ATPase pump. So there is no reduction in the volume of HCl secreted. So and when we divide this antacid, we have got two groups. One is systemic antacid. It includes the sodium bicarbonate and sodium citrate. Second group is non-systemic antacids, which includes magnesium hydroxide, magnesium trisilicate, aluminum hydroxide, megaldrate, and calcium carbonate. So systemic means they will be given as intravenous injections. Non-systemic means they will be given as oral route. The duration of action of these antacids is 30 minutes when given in empty stomach, and the duration of action is 2 hours when taken after a meal. So when we are taking these antacids before our meal, it acts for 30 minutes, and it is when it is given after the food, it can act about 2 hours. Okay. And we can go back to our some physiology of our gastric secretion. There are different phases of gastric secretions. Out of that, we have a basal secretion, and when we take some food, the gastric secretion increases. So this increased amount of secretions can be neutralized by this antacid when it's given after food. Okay, so when it's given before food, there will be a less amount of antacid, so it can act for only 30 minutes. When we are giving after a food, the gastric mucosa will secrete more acids. So these antacids can act more, or can act on more acid and act for more than 2 hours. Okay, and there are some important adverse effects that you have to know. The aluminum containing antacids or aluminum hydroxide like antacids, the important adverse effect is constipation. But the magnesium containing antacids, the important adverse effect is osmotic diarrhea. And when we are using these antacids, these aluminum containing antacids in the renal failure diseases, or the patients who is having renal failure, it can lead to aluminum toxicity, which leads to encephalopathy and osteoporosis. So the aluminum containing antacid should not be used in patients who have renal failure or some renal disease. And there are some common additives which are used along with this antacid. So the common antacid preparation will be having, or the syrups will be having, an antacid, a compound antacid plus some additive. The common additives which are used with the antacids are simethicone, alginate and oxytocin. Simethicone, it helps to decrease the surface tension, thereby reduces bubble formation, and also it helps to reduce the reflux. Okay, so it is more effective in patients who is having GERD, gastroesophageal reflux disease patients. So it will help to reduce the surface tension, and by reducing the bubble formation of these antacids, and also prevent the reflux. Next one is alginate. Alginate is also effective in GERD patients, as that it forms a layer of foam on top of gastric content and reduce reflux. So if there is a, I'll show a picture, I'll show the diagram. If the, sorry, if our stomach is like this, and here will be the esophageal sphincter. Okay, so when this alginate is given, along with the food content, it will forms a layer here, bubble like layer. So the movement of these contents towards the esophageal will be prevented. So the layer will be formed here, a soap like bubble. When we make some soap solution, we can see some bubbling above the water level. Like that, this alginate will form a layer. Alginate will form a layer on the food content and reduces its reflux to the esophagus. So if this is a esophagus, it will reduces the movement of food from lower to upper part. Okay, and next important thing is oxytocin. Oxytocin is like a surface anesthetics, so it will reduces the pain. Okay, it is like a surface anesthetic, it will reduces the pain. So if there is any erosion here and all due to the excess amount of acid, there will be pain. So the oxytocin will help to reduce the pain. And there are some important interactions for using these antacids. The important adverse effect or interaction is that they forms insoluble complexes. These antacids will adsorb along the drugs and form a insoluble complex that are not absorbed. So the example like tetracycline, ion salts, fluoroquinolones, H2 blockers, phenytoin, isoniazid. When we are giving the antacid along these drugs or with these drugs, they will form a complex which is insoluble and these drugs will not be absorbed from the stomach. The clinical importance is thus interaction can be avoided by taking antacids 2 hours before or after ingestion of other drugs. So if we are taking these sort of drugs, this group of drugs, when we are taking this group of drugs, we should not take simultaneously, either 2 hours prior or after 2 hours of the drug injection. Okay. Next group, prostaglandin analogues, misoprostol. It is a PGE1 analog. So prostaglandins are different types of prostaglandins are there. The misoprostol is a PGE1 analog. The different types of prostaglandins you will be seeing in the prostaglandin class. So just keep in your mind that misoprostol is PGE1, and it has got a modest acid inhibition. The inhibition is much less, but the important thing is mucosal protection. The mucosal protection is the important function done by misoprostol. It stimulates mucus and bicarbonate secretion. So it stimulates the mucus and bicarbonate secretion in the stomach cells. So it will form a barrier, or it can increase the defensive factor, and also it enhances the mucosal blood flow. The T half is short, 30 minutes. So we need to give 4 times a day. The T half of this misoprostol is less than 30 minutes. So along with every meal we have to give this misoprostol. That's why we have to take for more than 4 times a day. And it is the approved drug for prevention and treatment of NSAID induced ulcer. This is the approved drug, but it is not the drug of choice. It is the approved drug. So the mechanism of formation of NSAID induced ulcer is prevented by misoprostol. Okay, so the prevention and treatment of NSAID's ulcer is misoprostol, but the drug of choice is proton pump inhibitors. Okay, and important adverse effect is formation of diarrhea and abdominal pains. It is seen in more than 20% of patients using misoprostol. Next group, our fourth group, ulcer protective drugs. The important 2 drugs are sucralfate and colloid bismuth compounds. Sucralfate, it is a salt of sucrose complexed to sulfated aluminum hydroxide. Okay, so aluminum hydroxide is an antacid-like compound. To that, a salt of sucrose is complexed, that is sucralfate. In acidic pH, it polymerizes to viscous gel that adheres to the ulcer base. Okay, in your surgery classes or in your surgery textbook DAS, when you check or when you see the ulcer portion, the ulcer will be like this. The figure of ulcer will be there. So this is known as, this part is the base. So this part is the base of a ulcer. This is ulcer is a discontinuity in the normal mucous membrane or normal tissue. So this part is known as the ulcer. This is the edge. This 2 is the edge, and the lower part is known as the base. So when the sucralfate is used, the sucralfate will, in the acidic pH, it polymerizes and viscous gel is formed and it adheres to the base. So it will be forming a here. It will filling the base. So it acts as a ulcer protective. It helps for ulcer healing and all. So the sucralfate sulfate, sucrose sulfate binds to the protein physical barrier, and here it forms a physical barrier. So the base of the ulcer is more protected. It should be taken on empty stomach 1 hour before the meals, and it is not absorbed. So I already have told, it forms a gel and forms a physical protection. So it is not absorbed into the cells. So there is no systemic adverse effects, but it impedes the absorption of other drugs. So it is forming ulcer protection here, not along with the base, It will be forming like this. Okay, it will be a continuous process. So along with the edges and other tissue also, normal tissue also, it will be forming a barrier. But the important thing is it helps to form a barrier over the ulcer part or base of the ulcer. But it forms a covering over the normal tissue also. So it prevents the absorption of other drugs through the normal tissue. Okay. And the important adverse effects is constipation, hypophosphatemia. Okay, the important adverse effect of sucralfate is constipation and hypophosphatemia. Next compound is colloid bismuth compound. Again, this is also like our sucralfate. It coats over the ulcer. It forms a protective layer against the acid and pepsin. But there is an additional property. It stimulates the prostaglandin, mucus and bicarbonate secretion. So it has an additional property for increasing our normal defensive mechanism. And also another property of colloid bismuth compound is that direct antimicrobial activity against H. pylori. So this has got a two special mechanisms or special actions along with our protective layer. One is it forms or it stimulates the prostaglandin, mucus and bicarbonate secretion and increases the defense mechanism, and also it can directly act on H. pylori as an antimicrobial agent. And the adverse effect is it causes blackening of stool and tongue. It causes blackening of stool and tongue. It should not be used for a long time as it can leads to bismuth toxicity, which leads to encephalopathy. So it should not be used for a long time. Usually these are given for a short period of time along for the treatment of H. pylori diseases. And also it is contraindicated in renal failure patients. It is contraindicated in renal failure patients. Now we will move to our last part of our peptic ulcer, the treatment of H. pylori and GERD. So H. pylori and GERD. Both are different topics, but we will discuss this here. H. pylori bacteria. So what is H. pylori? Before H. pylori treatment, we have to know what is H. pylori. It is a unique bacteria ideally suited to live in acidic medium of human stomach. An important feature is that it is suited to live in the acidic pH of our normal human stomach. It produces urease. So this H. pylori can produce urease which convert urea to ammonia plus carbon dioxide. And due to this special feature itself, we are using this method or this urea for detection of the presence of this H. pylori. And this is the most common bacterial infection affecting more than 50% of the world population. Even though it has got only a less mortality rate, but it is the most common bacterial infection affecting more than 50% of world population. It can affect all age groups. And it also leads to gastritis, peptic ulcer diseases, gastric adenocarcinoma and malt lymphoma. So the H. pylori infection is more associated or mostly associated with gastritis, peptic ulcer diseases, gastric adenocarcinoma and malt lymphoma. So H. pylori, the bacterial infection, has got an association with some carcinoma also, that is in the gastric adenocarcinoma and also malt lymphoma. Okay. Now how we will diagnose this H. pylori? An important feature of H. pylori is it produces urease which convert the urea into ammonia and carbon dioxide. So we are using that process itself. One of the identification technique is by that process itself. And the diagnostic criteria or diagnostic tests can be divided into two groups. One is non-endoscopic test and the other one is endoscopic test. So non-endoscopic test, first one is serology. So we will be taking the blood or the plasma and we will qualitatively and quantitatively find out the amount of IgG against this H. pylori. Next important test is urea breath test. Okay, urea breath test and stool antigen test. These all are non-endoscopic test. Okay, urea breath test will be positive only when there is a live bacteria in our H. pylori. So it will produce the urease which will convert the urea into ammonia and carbon dioxide. So when we breathe out, the air will be having this ammonia and carbon dioxide. So only a live organism can produce this type of reaction. Okay, so this urea breath test is ideally used for to find out an live bacteria. Now endoscopic test. So we have, it is an invasive procedure. We have to put a endoscopic tube into our mouth and find the organism in our stomach, or take some tissue part to find out there is a organism. So histologically, and again a rapid urease test. So we will take a tissue part from the ulcer and do a urease test to find out the organism. And again we can do culture or polymerase chain reactions. Okay, so these all are the techniques used to find out the H. pylori. But out of all these, the live organism, if there is a live organism, urea breath test is the most adequate test. So while urea breath test, we can find out a live H. pylori organism. Now we will move to the treatment of this H. pylori. Again, here is the therapeutic goal for this treatment is ulcer healing and eradication of the organism. And the most important feature of this regimen is it is a combination of 2 antibiotics plus a PPI, provides a greater efficacy. So this is the better combination regimen used for treating this infection, this type of infection. It is a combination of 2 antimicrobial agent plus proton pump inhibitor. Okay, the first line treatment regimen or the treatment protocol for treating H. pylori infection is like this. It will be having a proton pump inhibitor plus clarithromycin 500 mg plus amoxicillin 1 gram. So each drug should be given twice daily for 14 days. Okay, 14 days. And in your textbook you will be seeing some other classification, that is sequential blockade or sequential treatment method and all. Nowadays, or the latest Maastricht criteria. Maastricht criteria is the gastroenterology group of doctors which forms the criteria internationally. So the Maastricht, according to the 2018 Maastricht guidelines or the latest guidelines, the most effective treatment period is for 14 days, and with the group of these drugs, 1 PPI plus 2 antibiotics. So this group of treatment is the most effective treatment, and it should be used for treating H. pylori. All other treatment methods are obsolete now. Okay, the second group of treatment drugs are PPA. Again, here a PPA, prostaglandin inhibitor will be there. Clarithromycin 500 mg. Next group is metronidazole 500 mg. Each twice daily. So each drug should be given twice daily for 14 days. So this is the latest recommendation of treatment of H. pylori. All other treatment methods or treatment regimens are obsolete now. So you have to study this treatment method. The sequential therapy, which you will be seeing in your textbook, this is obsolete now. That's why I have given in small letters or in the I want to just mention this sequential therapy, but this is obsolete now. We are not using this, and you no need to study this. For your Viva and all, it may be asking the sequential therapy, but the treatment method is obsolete. Nowadays it is not used or not recommended. The recommended one is the first 1 and 2. Now the treatment of persistent infection. When the 14 days treatment with our PPI plus 2 antibiotics is not effective, or when we do a endoscopy after the 14 days, again the infection is there, then we will have to move on to next group of treatment. This is known as quadruple therapy. The first group was triple drug therapy, means 3 drugs, 1 PPI and 2 antibiotics. That is triple drug regimen. Here it is quadruple drug regimen. Here there will be 4 drugs. Okay, the drugs are bismuth subsalicylate 525 mg, metronidazole 500 mg plus tetracycline 500 mg, each 4 times daily. So these 3 will be given 4 times a daily plus proton pump inhibitor or H2 blocker twice daily, same as our triple regimen, and again it is given for 14 days. Next group, where these metronidazole or tetracycline are ineffective, there we use proton pump inhibitors plus amoxicillin 1 gram plus levofloxacin 250 mg. And this regimen is recommended by the WHO for treating H. pylori infection in the African countries and all, where there is a severe case of H. pylori infection. These 2, last 2. Again, this is also given for 14 days, not 10 to 14, it's given for 14 days itself. Next, last treatment regimen is quadruple regimen. Again is this is not quadruple regimen, only the first one is quadruple regimen. So bismuth, subsalicylate, metronidazole, tetracycline and PPA. This is a quadruple regimen. These two is not a quadruple regimen. Okay, here the PPA plus amoxicillin 1 gram plus rifabutin 150 milligram each twice daily, again for 14 days. Okay, so when we are studying the regimens, you study the first two triple regimen, which I already mentioned, and also study the 4-drug regimen, that is a quadruple regimen with these 4 drugs: bismuth, subsalicylate, metronidazole, tetracycline and PPA. Okay. Now we move to the gastroesophageal reflux disease. So the gastroesophageal reflux disease is also associated with these type of acid-peptic disease. So we have to see the treatment modalities used in treating H. pylori, the gastroesophageal reflux disease. So what is GERD? Gastroesophageal reflux is a normal phenomena and cleared by saliva or esophageal peristalsis. So the reflux is a normal phenomena, but it is normally cleared by our saliva and the movement of our peristalsis. So the peristalsis, the normal movement of our esophagus from upper to lower side, will help to prevent that reflux. In gastroesophageal reflux disease, there is a prolonged contact of gastric content in lower esophageal and the patient has persistent symptoms. In reflux esophagitis, there is inflammation, erosion of lower esophagus. So again, when we see the we can see here, consider this is the intestine and the stomach will be there. Okay, there is a sphincter there will be a sphincter which crosses the lower side, lower esophageal sphincter. So consider this is a lower esophageal sphincter. Normally this sphincter has gotten property to open. So the contents in our intestine or in the stomach can move upwards. So it is prevented by the movement of saliva and also peristalsis from upper side. So the saliva and the peristalsis will prevent this movement of our gastric contents. So if there is a gastric contents here, the acidic contents will not move upward. And if there is any abnormality in this region, there will be reflux and it can causes the movement of our acidic drugs or acidic contents to our esophagus and causes irritation of this mucosa of the esophagus and leads to reflux esophagitis. Pathophysiology of GERD. Causative factors: poor esophageal peristalsis, impaired pinch-cock effect of diaphragm due to hiatus hernia, transient lower esophageal sphincter relaxation, low esophageal sphincter tone. Low esophageal tone fails to increase when intra-abdominal pressure rises, heavy meal, pregnancy, bending, etc. So during that time the intra-abdominal pressure increases, it will leads to low esophageal sphincter tone and the contents will be refluxed outside, and also delayed gastric emptying. So all these factors or all these conditions, there will be reflux of contents in our stomach to esophagus. And there are some associated factors also: obesity, pregnancy, tight belt, large or fatty meals, chocolate, coffee, alcohol, smoking, drugs like anticholinergic drugs, calcium channel blockers and nitrates. Diseases like hiatus hernia will increases the symptoms or which will leads to the reflux of the contents. And the symptoms will be the first and foremost, the important symptom is heartburn or chest pain, which increases on bending and lying down. So when there is a bending or lying down, the contents will move upwards, and if the esophagus is irritated, again the acid contents will increases the irritation. The pain increases by drinking and eating. So when there is pain during drinking and eating, there is a chance for esophageal inflammation. There will be sour taste in our mouth. So sour taste in our mouth due to the excess acidic material which comes from the stomach to our mouth. And there are associated wheezing, chronic cough, asthma and all. Excessive salivation, tooth erosion. So there will be some discoloration of the tooth and all, erosion due to the acidic amount. Normally our saliva is a alkaline medium, or the acidity in our pH in our mouth is alkaline. So if these acidic contents come to our mouth, it leads to a sour taste and also excessive salivation and tooth erosion. And the treatment depends upon the severity of GERD. So the treatment of GERD depends on the severity of GERD. The severity of GERD can be classified into 3 stages: stage 1, stage 2 and stage 3. In stage 1, it is occasional heartburn, so less than 3 episodes per week, mostly only in relation to a precipitating factor, mild symptoms and no esophageal lesions. So there will be only a mild symptoms. Occasionally there will be symptoms of heartburn, less than 3 episodes less than 3 episodes per week, and the pains or the symptoms will be precipitated due to the factors. So only when there is some factors there will be pain and the symptoms will be mild, and when we do a endoscopy there will be no esophageal lesions or any erosions. In stage 2, there will be more than 3 episodes per week of moderately severe symptoms and nocturnal awakening due to regurgitation, esophagitis present or absent. So endoscopic, sometimes there will be esophagitis, signs of esophagitis, but the symptoms, there will be more episodes of symptoms, and even in night symptoms and the break of our sleep and also due to the regurgitation there will be some awakening in the night also. In the third stage, there will be daily or chronic symptoms: disturbed sleep, esophagitis, erosion, stricture, extraesophageal symptoms like laryngitis, hoarseness of voice, dry cough, asthma and all. And the symptoms occur soon after treatment stop. When we do some treatment and when this treatment is stopped, again the symptoms starts. So this is a severe condition of GERD. There will be associated with the other features like laryngitis, hoarseness, dry cough and asthma. Symptoms like asthma will be there. So this is a severe situation, and the treatment is also different for severe GERD. Now the drugs for GERD. The treatment of GERD is individualized according to the severity and stage of disorder, which I have already told. So the treatment methods or the group of drugs used will be different for different stages. Here the drugs used are proton pump inhibitors, H2 blockers, antacids, sodium alginate and prokinetic drugs. Prokinetic drugs, which you already seen in the antiemetic class, prokinetic will help to increase the tone of lower esophageal sphincter and also will helps to release the tone of our duodenal sphincters. So it increases the peristalsis. Okay, so in the figure you can see that it will reduces the upward movement and increases the forward movement. Okay, and the alginate I have already told what happened in alginate. It forms a layer of foam or a layer of coating over our contents, which help to prevent the reflux. And again the H2 and PPIs, H2 blockers and PPIs will reduces the HCl secretion, and the antacids will helps to prevent the already formed HCl or neutralizes the already formed HCl. So the mechanism we have already seen. Okay. When the symptoms is mild to moderate, important treatment modalities are change in lifestyle, reduce body weight, avoid heavy or fatty meals, avoid smoking, rise head end of bed. Then antacids, aluminum hydroxide, magnesium hydroxide, magnesium trisilicate, which neutralizes the HCl. Alginate containing antacids forms a gel or foam on the surface of gastric content and prevent the reflux. And H2 receptor antagonist. ranitidine, which decreases the HCl secretion. So this is the group of drugs used when the symptoms is mild to moderate. When there is a severe GERD, so stage 3 GERD, we will have to use proton pump inhibitors like omeprazole or omeprazole, which reduces the HCl secretion, and it requires prolonged therapy for many years. So this treatment may be prolonged for a long, even sometimes may takes 1 year for treating a patient. Prokinetic drugs, metoclopramide, domperidone. Okay, metoclopramide and domperidone, like a prokinetic, which increases the peristaltic movement and also increases the tone of our lower esophageal sphincter, which increases the lower esophageal peristalsis, which increases the gastric emptying. And also for a severe GERD cases, it will be associated with H. pylori infection. So as a preventive measure, always when there is a severe GERD, when the extraesophageal symptoms like laryngitis, asthma all are present, the physicians will prefer to give a H. pylori eradication program also. So 14 days treatment of H. pylori also is given. So that's all. We have finished our drugs for peptic ulcer diseases, and I hope these presentations will be helpful for you, and you should read the concerned topic in your textbooks, and also you have to attend the MCQ online quiz. Okay, so you can text our faculties, or you can mail in your Google. If there is any doubt, you can ask at any time. So we are there for helping you, and I'm stopping here. Stay home, stay safe. Thank you.